Good afternoon, all. Thanks for those who are joining in early. We're going to be starting soon. Let's just give maybe 3 minutes to those who are joining late, and then we can start. Thanks for coming in time. Those who are just joining in now, we're giving 3 minutes to those who are joining so that we can start. Happy New Year to you all, and thanks for joining in time. Hello, everyone. We're giving time to those who are joining in now. We'll start shortly. We are starting shortly. We're just giving time for those who are joining now. In 3 minutes, we'll be starting. We're giving time to those who are joining now. And thanks for those who managed to join in time. And welcome, everyone. Feel free to start introducing yourself in the chat box. We are starting shortly. Yes, Ephraim, I see your hand is up. We are starting shortly.
Yeah, the chat is disabled. The chat.
Okay,
Maybe
thanks.
you can just enable it. Thank you.
Yes, Mirel, would you kindly activate the chat box? Our attendees are saying.
Yes.
Yeah, thank you. Okay, I think we can get going. Those who join, they will find us on the way. A warm welcome to you, to everyone. Greetings and Happy New Year. Looking forward to working with you this year. Welcome to the MENT webinar series where we discuss anything pertaining to men and boys. So you're going to be receiving the slides. We are recording this webinar, so you receive slides and you also receive recordings of this webinar very soon. Usually we manage to send these slides a day after the webinars. We always like to make these webinars very interactive, so let's make use of this chat function to exchange, to share ideas, and also to interact. Also, there is a Q&A function. Let's make use of that Q&A function specifically to ask questions. So let's separate our comments, our feedback, so that we have questions, specific questions on the Q&A function, and then our general chats on the chat function, where we can make this webinar as interesting as it can be. Thanks again for joining, and happy to see everyone, happy to see familiar faces. For those who are joining these kind of webinars for the first time, this global working group was launched in March 2021 after seeing data speaking to the need to focus on this population addressing HIV services gap. This slide is just showing what we focused when we were launching this global working group, and part of its work is to run these webinar series where we bring people who are doing interesting work on the topic to share with others. So basically the group tries or aims to coordinate activities related to improving outcomes on HIV services across the HIV cascade for men. Also, we work to develop with a specific technical working group to support the development of operational guidance for improving HIV services for this group, identifying interventions and approaches that work to address this HIV service gap that we see in men and boys. We identify making use of the different technical expertise on the group. We identify, we collect, and we share these best practices. And this webinar series are a form of us sharing these best practices, where we invite people doing work on this topic to share with others. We also use this platform to disseminate our guidance briefs and lessons learned, and support the scale-up of effective interventions, including providing technical assistance as needed. We have done a lot of these webinars. I think we've seen in the invite, it says episode number 8. So which means we have done 7 of these similar webinars before, cutting across different topics. We look at the science, where the data is generally speaking to, while focusing on men and boys. We've covered topics such as U equals to U. We have done topics around men and PrEP. We've done topics around some of the issues around the trauma that men as children face when they're growing up, and how that impact their health-seeking patterns. And today we are going to be focusing on a different topic. We are going to be looking at insights and lessons on reaching adolescent boys and young men with HIV services. We've got a very interesting, exciting, and also very knowledgeable panelists that's going to be looking at this topic. First of all, we're going to hear from Wale from WHO, who is going to provide an overview summary of the new Managed HIV framework. Those who were at ICASA last year in December, you might have been part of a satellite session that covered this. But for those who are not able to be at ICASA, we have asked Wale to do a summary overview of what he covered at ICASA, so that we are all on the same page and we are aware that there's this new resource that we're all excited about. So Wale will give us a summary overview of a framework that was developed focusing on Managed HIV with a people or person-centered health service approach. Then we'll hear from our 2 presenters. I'm very excited to hear from them. We're going to hear from Rose Kanyemba, as well as Leslie Gittings. Rose is going to focus on HIV-focused sexual risk reduction interventions targeting adolescent boys and young men in sub-Saharan Africa. And Rose is based at University of Pretoria, South Africa. And then Leslie also bears two institutions here, Western University in Canada, as well as University of Cape Town in South Africa. She's going to be highlighting or providing insights and lessons on reaching adolescent boys and young men with HIV services, and she'll highlight the specific topic that's going to be covering there. We'll have a good time to cover questions and discussions, and Sean Malone, who is also one of the co-chairs of this working group, is going to help facilitate this Q&A session. And then we'll hear closing remarks from Wale from WHO as well. So without further ado, I would like to invite Wale to provide us this overview summary of this new framework that was launched at ICASA, especially for those who are not able to be at ICASA. Over to you, Wale.
Thank you very much, Lysias. If you can hear me, I'll just you can stop sharing, and then I go ahead and share my screen.
Perfect, loud and clear.
Is it showing well? And is it full screen?
Yeah, we've got it.
You got it. Okay, thank you so much. And let me join Lysias in welcoming you all to this webinar today. Like Lysias said, we will be focusing on adolescent boys and young men, a really important topic. However, we thought to go back a bit. In December at ICASA, we had a satellite session where the new framework on men and boys was launched in front of quite a packed audience as well. It's been quite back and forth since then. I've received so many emails from countries asking how they can get the presentation, or how they can begin to get the support towards implementing the framework. So it is my pleasure to sort of run through the same presentation at ICASA for those who were not there, and to sort of spur us on towards the rest of the webinar and listening to the other really great presentations that we'll be hearing on boys and men today. So the presentation follows just four areas. First of all, speaking about whether the focus on men is a distraction or actually a really important imperative, whether it's an imperative or a distraction. I'll speak a bit again about what the impediments are, what are the things that are stopping us from moving forward, with confidence and with the sort of support that we need towards having something solid for men and boys. But then again, what are the solutions? This is where I will speak a bit about the framework, but of course, I won't be going too in-depth into it, as you will be getting, of course, a blueprint of the framework, but also how you can download and begin to disseminate. And finally, I would make a few closing remarks. So is it a distraction or an imperative? I'm sure many of you, you've joined this webinar because you are interested in the men topic. There is a lot of, I would say, pushback, right? Many of you working in countries on boys and men, there is that pushback, on focusing on men and boys. We're not going to, put our heads in the sand and say, that is not happening. I think part of that, of course, is because a lot of people, quite erroneously as well, think that focusing on men distracts from the focus on other populations. And again, this is where I think many of us, that's the discussion we need to have, isn't it? We need to have that discussion about how the focus on men is not just for men themselves, but also for other populations, which of course then makes it an imperative. It becomes really important as we move towards 2030 and begin to speak about ending AIDS or eliminating HIV. How do we make sure that we are on the right path towards that? Well, the gaps are clear, and you know, we've seen this over and over and over again. It sometimes, you know, doesn't shock us anymore. The gap between men and women across the cascade, the 95, 95, 95 cascades, you know, is as clear as night and day. And you can look at the middle part there. There's close to a 10 percentage point gap between men and women on ART coverage, but also on viral suppression. I'll come back to that in a bit, but it's really important that ab initio, we sort of look at, you know, these cascades with the data that we have, you know, the sort of hardcore evidence that shows that across that cascade, men are without a doubt behind. The point as well is not just whether men are behind, it's also because of the trend and the widening gap. So this is data from 2010 going to 2022. And you can see that, you know, how the gap, you know, sort of, you know, opens up from year on year on coverage of ART. Again, we're going to be looking at how it is so critical to begin to close this gap, not just for men, but also for other populations as well. I've added this slide to show that, you know, the regional you know, differentiation of the gaps, which shows that, you know, this gap is actually more pronounced in some regions compared to others. So we've seen in Eastern Europe and Central Asia, East and Southern Africa, you know, the Caribbean. You know, to be fair, all regions, you know, have this gap, but you know, certainly in some more than the others. At ICASA, I also showed a glimpse of this fresh new study. It's actually been published now in the Nature Microbiology journal just this year, and it shows how critical, right, it is that we actually focus on men, just in support of what I had said earlier. Two key messages from this study, which, you know, which comes off, you know, some really fantastic modeling work from the Pangea Network, is that closing the gap, the gender gap between, you know, in viral suppression between men and women, would actually have reduced infections in women by up to 50%. I'll take that again. If we had increased the support that we give to men, putting them on ART, reducing the viral loads of men, and suppressing the virus in, you know, in the majority of men, we could have actually reduced new infections to women by up to 50% in past years. The paper further showed that, you know, it's not really about casting our nets wide. There is actually, you know, a subgroup and an age group of men that would be of the greatest benefit in closing the gap, but also in averting new infections, and that's men between the ages of 25 and 40. I invite you to you know, to look at this paper. It's in an open access journal, and we'll be sharing this after the call. But it just tells you how critical it is that we begin to, you know, sort of change tack, right, and see how we can begin to look at a holistic way and a holistic path towards ending AIDS. I'm going to go through this very quickly. It's just to show that that burden is not just within HIV alone; it's across, you know, quite you know, other disease areas as well. It's STIs and hepatitis. You know, we know men living with HIV are nearly twice as likely to die from TB. We know, of course, that TB is the number one killer of people living with HIV. And of course, advanced HIV disease. Men are twice as likely to present first time with CD4 counts less than 200. So again, just a tide rationale. So it's why we should focus on men. It's the transmission dynamics. It's the inequality in terms of access to testing, treatment, and viral suppression. It's the data gaps across 95, 95, 95, and of course, it's about ending AIDS. So what is stopping us? What is stopping us? I mean, your guess is as good as mine. I would actually like to hear from you why you think, despite the mountain of evidence, the global response on men is not really as holistic as it should be. What is about stigma? It's about risk perception. It's a lack of routine entry points for men. It's of course the facility model, in terms of how healthcare workers relate with men, the peer support that is needed, but also the sort of siloed services that we sort of provide, which does not serve men well. This is always something I like to quote, but it's really fantastic work from Malawi, which showed that, when we say men don't like to go to facilities, but, again, the question is, what do we do when men come? So this is work that was done in a couple of years ago that showed that of the men that came to, facilities, outpatient clinics, for instance, only a tiny fraction, only 7%, actually got offered HIV testing. So that just tells you of the missed opportunities based on the narrative that we create in our heads about men. So what are the solutions? What can we do? The solutions, of course, are plethoric. So there's so many. But here I'm going to focus a bit on the new WHO framework. I think one of the really key questions has been, we don't have guidance. We don't have, there's no document that can help us to go through what we need to do and so on. We launched this, at CASA, again, with UNAIDS and other partners, and it's a new framework. It's men and HIV, evidence-based approaches and interventions on how we can reach men. So I'm inviting you all, from the different countries to please, get this QR code, look at this document, and we want to see how countries can begin to latch onto this launchpad and to this platform to reach men. So I'll go through a bit of what the document, without emphasizing, right, what the document contains. But just to say that, first of all, we focused on a person-centered framework. You get to see what that means in the document. We carried out a scoping review. So this was, very scientific. It's evidence-based. The scoping review was actually going to be published in a couple of months. It's already in the works to get it published. So we did the scoping review, which helped us to identify across different pillars the approaches and the interventions for reaching men. But of course, there were quite a few gaps in the scoping review as well. So we were able to identify gaps and additional steps that are needed. So this is what the framework looks like in summary. It goes through 3 pillars. So it's not a framework that goes all over the place. It's just 3 core components. First of all, it's about access, it's about quality, and it's about supportive services. So in the document, you'll be able to see quite a few sub-components on access, including service location, entry points, community, and so on. We looked a bit about quality as well. What are the key quality parameters? And then finally, what sort of supportive services, including virtual and peer support, that men need to be able to access services, but also to be retained in services. Without going too much into it, the framework also provides the different barriers, across those pillars that I mentioned. So for access, you'll be looking at what are the different barriers, to access, and what are the solutions. How can we tackle those barriers? How can countries begin to look at, an evidence-based, barrier-scoped solution, to reaching men. So we have that across access, across quality, and across supportive services. So that tells you how specific as well this framework is. But in summary, it looks at having male-friendly, adaptable, and integrated sort of services for men. At the back page of the framework, you would find the evidence-based WHO recommendations. So WHO is in the business of giving recommendations across the cascade. So you will find across prevention, testing, treatment, STIs, hepatitis, TB and HIV, but also broader health interventions. What are the WHO recommended interventions across this cascade that you would find in the framework as well? I'm not going to say too much about this. Lisa has covered it, but of course we have the Men and HIV group, which actually are the ones bringing you this webinar. It's a small group of aficionados and advocates of men. If you would like to join this group, right, we need especially people who will be able to bring in unique perspectives from global to country, even sub-country. Please let us know. I will be more than happy to co-opt you. Finally, it's about, this is my last slide, and I've just added this slide, to say, we talk about the path to ending AIDS. I'm not sure there is a greater path that is more straightforward, that is more evidence-based, but that is also commonsensical as well, in terms of how we can reach men and how we can end AIDS, really. I think there's a lot said about adolescent girls and young women, and rightly so. We know that 4 in 5 new infections in East and Southern Africa, for instance, are amongst adolescent girls and young women. So they bear a disproportionate burden, right? However, we need to think deep and think the long game to understand what the sources of those new infections are, right? Many people will tell you that the sources, and in fact, the paper that I shared earlier shows that it is, men, particularly between 25 and 40, or heterosexual-driven epidemics. We know that key populations, as well bear, the greater percentage, particularly of new infections. We know that close to 60% of new infections are amongst key populations and their partners. But then again, amongst key populations, we know that that men are at the center of key populations. So we're talking men who have sex with men, people who inject drugs. Between 80 and 90% of those are men. People in prisons and in closed settings, close to 90% of men. And even sex workers, you find that the main thing about sex workers is not just the sex work itself, but it's about the partners. What that means is that, dare I say, all roads lead to men to end the AIDS epidemic, but also to sustain it in terms of sustaining the number of new cases going forward. And I just invite you to collaborate, to work with us on reaching men, and to try to see how we we end this this epidemic, not just for men, but also for other populations as well. So I'm going to stop there and stop sharing my screen. Happy to answer any questions as I hand over to, I think it's Rosalind who will be presenting next now. Over to you, Rosalind.
Good day, everyone. My name is Rosalind Kanyamba, and I work from the University of Pretoria. Before I begin, I'd like to extend my gratitude to the organizers of this event. I'm indeed privileged to be here. Allow me to share my screen. Can someone confirm if it's visible?
Yes, it is perfect.
Okay, thank you. So my colleagues and I, we conducted a scoping review titled HIV-Focused Sexual Risk Reduction Interventions, Targeting Adolescent Boys and Young Men in Sub-Saharan Africa. Okay. So this review was in response or an answer to a call following the core principles of the 17 Sustainable Development Goals that no one should be left behind in the AIDS response, and also the core principles, okay, let me move on. So we acknowledge that adolescent girls and young women, there's sort of an exceptionalism with HIV interventions, leaving the boy child behind. And thus the boy child is becoming marginalized and underserved population. Adolescent boys are seldom addressed in HIV prevention policies and programs.
I'm afraid I think we've lost the Roslyn, haven't we? Yes.
Yeah. Let's just give a few seconds and see if it's just a network bandwidth. She seems to be back. Rosalind, do you mind resharing your screen? Your screen is gone. Do you mind resharing? Can you hear us, Rosalind?
Yes, I can hear you.
We lost you. Maybe if you can reshare your screen. Yeah.
Okay, is it visible now?
Yes. If you can put presenter mode, and then yeah, perfect.
Okay, my apologies. I'm in the middle of a storm, so my network is a bit rough. So adolescent boys and young men, they have a combination of risk factors, mostly some of them resulting from masculinity norms that emphasize risk-taking as a sign of a real man. And this includes having condomless sex, sex under the influence of alcohol, multiple sexual partnerships, and poor health-seeking behaviors, and not testing for HIV, among others. So despite adolescent boys being at lower risk of HIV acquisition than girls, they are still at risk. Adolescent boys increase prevalence as they age, and adolescence is a critical time for the formation of attitudes towards sex and sexual behaviors. In sub-Saharan Africa, which is the epicenter of the HIV epidemic, 43% of boys and 53% of girls have had sex before age 18 in the period between the years 2000 and 2015. And also there were fewer deaths due to AIDS-related illness among girls and women in 2019 than in 2010, compared to 32% fewer deaths among adolescent boys and young men over the same period, which indicates a worse AIDS mortality risk for adolescent boys and young men than for adolescent girls and young women. So the aims of the scoping review we conducted generally aimed to provide an overview of interventions that have targeted sexual risk behaviors of adolescent boys and young women in sub-Saharan Africa between the years 2000 and 2020, with critical insights on what works in preventing risky sexual behavior that could lead to HIV transmission. So these were the central research questions of the review, to find what evidence-based HIV-directed sexual risk-directed interventions, what exists for adolescent boys and young men in sub-Saharan Africa over the review period, and how effective have these interventions been in mitigating HIV risk. Methods of review, I'll just summarize. We use the Joanna Briggs scoping review template And the population, we aimed at adolescent boys and young men aged 10 to 24 exclusively, or interventions that included this population, and also disaggregated results by age and gender. Our studies of interest included behavioral, biomedical, social, and structural sexual risk reduction interventions, and also interventions that targeted the effectiveness in reducing sexual risks among ABYM. Studies were from Sub-Saharan Africa, and we targeted published peer-reviewed data, qualitative, quantitative, and mixed methods research, and experimental and quasi-experimental studies, randomized controlled trials, evaluation surveys, controlled before and after studies, and impact evaluations. And because we had limited resources, we also only targeted those that focused on English language only. So this is a summary of the data extraction, and we got 29 studies from this. And the characteristics of the interventions we included in our studies, they were varied, and majority used the combination type approach. And messages from these interventions included biomedical, norm-changing behaviors, structural and psychosocial determinants of HIV transmission, which are also strong predictors of health outcomes. Delivery of the interventions we included was through mass media communication, dialogue, drama skits, poetry, puppetry, role play, workshops, and education curricula, as well as sports games. For the facilitators of the interventions we included, they were varied and included religious leaders, trained medical personnel, and religious leaders, and general community members who were of good standing. These interventions were both in and out of school, and our context was varied and included urban, rural, and also peri-urban. So for the findings, the overall exposure of the interventions varied from as short as 2 weeks to 5 years. And our measured outcomes, as I said before, included behavior, norm-changing biomedical and structural measures. Overall, the studies reported positive outcomes, but there were also some that reported negative as well as no effect outcomes. On the measured outcomes, the interventions included 6 out of 9 measured multiple sexual partnerships, and 9 interventions measured multiple sexual partnerships, and 6 of these were successful, and this was measured at 12 months follow-up. 3 interventions did not have significant effects on multiple sexual partnerships. For example, the condom technical skills intervention actually reported an increase in self-reported multiple sexual partners among adolescent boys and young men at 6 months follow-up, maybe because of the false security of having used condoms. 7 studies measured abstinence, and 4 of these reported an improvement in secondary abstinence. 1 study measured intergenerational sex, and it recorded no effect. Alcohol and drug abuse was measured in 4 interventions, and all recorded a success through reduced consumption using random drug tests. 5 studies measured knowledge about HIV/AIDS, and 3 of these were successful and noted improved HIV knowledge, attitudes, perceptions of social support, and HIV prevention. However, there was differential impact with regards to gender, with 1 of these interventions, the Mzake and Dimzake, which found that intervention had effect on boys aged 13 to 15 years compared to females of the same age. Then there was voluntary medical male circumcision measured in 4 studies, and all of these recorded success with improvements in uptake, and this was measured through clinical records. 8 studies were concerned with HIV testing, and 7 of these recorded an improvement in uptake. Only one of these, the Sawira intervention from Zimbabwe, reported no difference in HIV testing uptake pre and post intervention. 8 interventions were concerned with norm-changing outcomes, and 6 of these noted a positive outcome in male controlling behaviors targeting women, and this was effective in recordings of less gender-based violence and sexual violence. These were validated through police or hospital records of physical or sexual violence committed during the preceding 6 months. Only 2 studies were concerned with measuring livelihood strengthening outcomes. The Stepping Stones intervention, Stepping Stones and Creating Futures, found no improvement in past month earning savings for both men and women at 24 months follow-up. And this Siaka Ninja program recorded improved budgeting and planning skills in school-going boys and girls aged 14 to 16 years, only in the intervention group at the 18 months follow-up. In this intervention, participants were more likely to have attempted to open a bank account when compared to the control group, and less stealing in the past weeks was recorded. A general improvement in condom use was reported in 8 out of 15 interventions, with condom use being consistent in one of the interventions called the condom technical skills intervention, and this was at 12 months follow-up. Again, there was differential impact across gender in these studies that measured condom use. The HealthWise program noted that boys had greater condom use self-efficacy than girls at both baseline and endline studies. Africa Youth Alliance intervention increased condom use, consistency of condom use, and contraceptive use among females, but not male participants. And this intervention from Kenya, the Path Kenyan Scouts, the proportion of sexually active boys between the ages of 15 to 18 using condoms increased compared to girls of the same age. Lessons learned from this scoping review, we noted that unidimensional programming were less successful. Combination approaches programming were successful. For example, the condom technical skills intervention, as I said, it improved condom use, while simultaneously increasing multiple partner sexual activity among participants. Its part failure maybe was because it was unidimensional and it neglected the related aspects of sexual behaviors. Condoms may help in ensuring safety, but this is only applicable when they are used correctly and consistently. Another lesson was mixed gender interventions created a safe space for adolescent boys and young women, adolescent boys and young men, and adolescent girls and young women to explore gender and sex roles in a safe space. Sex segregated groups are important because men and women in early phases of sex are at different levels of sexual awareness. So gender-specific interventions may be more suitable, at least initially. Another lesson was that a network approach, friendship network approach is important because of their interactive and communicative nature. Participants can construct messages and meanings of their social realities in their friendship groups, and this has the potential for fostering transformation towards healthy masculine attitudes. And also these friendship networks, they have supportive elements through encouragement, affirmation, and social support, so they tend to be more successful. Again, interventions need to be tailored with active participation and input from the targeted population for better outcomes. In other words, they promote two-way dialogue, equitable participation, local ownership, empowerment, and social change. Nothing for us without us. In other words, include the target population in interventions affecting them. Outcomes from this review also suggested that communication channels such as media, although they are said to perpetuate harmful gender norms, they can also be potential avenues for shifting attitudes, norms, and behaviors. They just need to be carefully considered, and the messages need to be targeted in the right channels to reach the intended targets. Structural interventions, they are often critiqued as social development rather than focused health interventions, but they prove that they can alter the context of young people's HIV risk by improving personal agency. Use of facilitators, such as use of soccer coaches or soccer players who are well regarded, or the use of religious leaders, contributed to intervention success, because this can also work adversely if it is not structured well. So engaging influencers like this provides wraparound support for adolescent boys and young men, and having also specific activities such as soccer matches targeting these influencers, and use of diversity of methods to engage ABAYM contributes to success. However, for the review, we noted that program sustainability was a problem. Most of the interventions could not be sustained after the intervention had ended. So the ability to maintain programming and its benefits over time is critical for achieving health benefits for the intended population in which positive change is desired. Our recommendations after having conducted the scoping review, we noted that mixed gender approaches should be adopted, and findings also suggest the importance of introducing topics in sex-segregated groups. Again, interventions need to be tailored according to the target population to optimize success. Age-appropriate interventions are more effective, and combination social protection response may be more effective than unidimensional programming. And also peer intervention must be implemented with meaningful youth participation. Our scoping review had its limitations, which might have led us to skip some interventions which might have contributed to its strength. We excluded some interventions from the review if study results were not stratified by age, gender, or sex. And many studies in the review relied on self-reported measures of behavior change. Self-reported outcomes reduce confidence in demonstrating intervention efficacy. And study designs of interventions in this review lacked commonalities. Some were randomized controlled trials and some were qualitative studies. And this suggested a little consensus on the optimal approach to evaluating these studies. Behavior change is hard to sustain, so identifying facilitators and barriers is key to understanding implementation processes and promoting impactful interventions. Properly conceptualizing interventions from the outset is crucial for program sustainability. So a summary of what we found out is interventions targeting sexual risk among adolescents and young men in sub-Saharan Africa, they show promise, especially those that promote combined risk reduction interventions. The review found a positive impact of interventions on condom use, reduction of multiple sexual partnership, abstinence, alcohol and drug abuse, and HIV testing, as well as livelihood strengthening interventions, suggesting that we are in the right path. Where gender, age, and grade variables were employed in study designs, effects were mixed, and therefore future studies need to pay more attention to these variables when designing and evaluating interventions. Interventions reduced risky sexual behaviors, but change was not sustained. Future interventions require more longitudinal studies, including a qualitative and process-level methodology to document why health behaviors may not be sustained in specific contexts post-intervention. Engaging ABYM in HIV prevention interventions should occur in ways that do not harm, but promote gender and sexual diversity, equality, and health for all. I'd like to acknowledge the South African National Research Foundation, NRF, and the Swedish International Development Agency, SIDA, who funded our research for the scoping review. I thank you. Back to you, Licious.
Thanks so much, Rosalind, for such a comprehensive presentation. Lots of detail and analysis of the results of these HIV focused sexual risk reduction interventions targeting adolescent boys and young men. We're now going to hear another interesting aspect on insights around adolescent boys and young men in HIV services. We're going to hear from Leslie. Leslie, who is an assistant professor at Western University School of Public Health in Canada and also a research associate at the University of Cape Town in South Africa. She's going to present on becoming men, biosocial lives of adolescent boys and young men living with perinatally acquired HIV in the Eastern Cape in South Africa. Over to you, Leslie. And let's keep on exchanging with the chat. I see so many chats being posted in the general chat function, and there's been so many questions already in the Q&A function. Let's keep them coming. Our panelists will be responding to those as we proceed. So over to you, Leslie.
Great, thank you. And I just wanted to check, can you see my screen? And are you seeing the full screen?
Yes.
Okay. Are you seeing speaker notes or just the screen?
No, just the right presentation. So it's
that's awesome.
good format.
Great.
Thank you.
Thank you. Well, hi, and thank you so much for having me here today. I'm calling in. I was telling Wole from London, Ontario in Canada, where our local authorities have advised us that our temperature will be negative 30 degrees today. So we have a cold weather advisory. And here I'm an assistant professor at Western University, and I'm also a research associate at the University of Cape Town in South Africa. And that's where I conducted my doctoral work. And it's really a privilege to be here today. And what I'll be doing today is I'll be presenting on research that aim to explore and document the biosocial lives of adolescent boys and young men living with perinatally acquired HIV in the Eastern Cape of South Africa. So I'm actually not going to spend much time on this because Wole and Rose did a much better job than I could in terms of providing background. But just to say, the context in South Africa is very similar for adult men as what was shared about the global context. And adolescence presents further challenges in the HIV epidemic. ART coverage remains quite low in this group. And even when they do receive ART, non-adherence is high. And findings from the same study that I'll be presenting on found 66% past week adherence among this group. And it's for these reasons that in Eastern and Southern Africa, age-related illness causes a high proportion of adolescent deaths. So what about adolescent boys and young men living with HIV? Rose spoke to this, so I won't add too much, but just to say also that there is a small evidence, which is still quite thin and a little bit inconsistent, that documents troubling rates of low HIV diagnosis, linkages to care, and adherence among adolescent boys and young men. For example, a 2017 study in Cape Town found that elevated viral load was significantly associated with being male and older age, so older adolescent boys rather than younger ones. And similarly, a study of adolescents living with HIV in Zambia found that being male was significantly associated with reporting incomplete adherence. Today, I'll be presenting on findings from a sub-study of Mzansi Wako, which was the largest known study of adolescents living with HIV globally, conducted between 2014 and 2019. The PIs on the study were Drs. Lucy Kluver and Rebecca Hodes, and this was a mixed method study that aimed to identify risk and protective factors for ART adherence among adolescents. It took place in 2 areas of the Eastern Cape in South Africa, Buffalo City and Amatole, in a mixture of urban, peri-urban, and rural areas. And most of the participants in this study were living with perinatally acquired HIV, as their mothers did not have access to prevention of mother-to-child transmission. It was before the rollout in the province. And the sub-study that I'll be presenting on today was called Ezobudoda, or Isixhosa for manhood things. And we engaged a variety of qualitative and arts-based methods with adolescent boys and young men aged 13 to 22. We conducted art-based life history narrative interviews to understand life and health experiences of this group, followed by a round of semi-structured interviews about health beliefs and practices. And we also extracted and analyzed clinic files for the same participants. And to complement the research with adolescent boys, we also interviewed biomedical as well as traditional health practitioners. And just to say, all of the pictures shared here of adolescents are anonymized, and all other pictures are shared with consent. So the research aims were to understand the health beliefs and practices of adolescent boys and young men living with HIV, and also how these beliefs and practices were formed and shifted over time and throughout the course of adolescent boys and young men's lives. The first findings that I'll share with you are about life and health histories. And here is an example just to give you a sense of the method, as well as some of the key themes that emerged in this research. So this is a participant's narrative who we'll call Kwezi. You can see on the top left, there's a small image of a life history narrative interview where he used the metaphor of a river of life to map out major life and health events. And what we then did is we triangulated his drawing with interview data and his clinic file. And the 3 themes that emerged most commonly in this research were young experiences of maternal death, which often spurred boys finding out their own HIV positive status. And then participants also frequently spoke about severe experiences of childhood illness. For example, Kwezi's clinic file showed the death of his mother, testing positive for HIV, and then being sick with tuberculosis. And what this did is it provided boys difficult young experiences of very embedded engagement in biomedical care. So while these experiences were talked about as very difficult, this subgroup of adolescent boys living with HIV, we believe, had different tools and experiences to navigate the health system because of their early experiences of illness, as well as a belief in the efficacy of ART because they experienced its effects quite young. The last theme that I wanted to mention was, like Kwezi, many boys grew up not knowing their fathers. And when we asked about where they saw themselves in 10 years, participants spoke about their early experiences as a way to describe what they ideated for in their lives. So participants spoke about engaged fatherhood, where they wanted to be present for their children and provide for them in ways in which their fathers could not. And you can see that here in these quotes. And then these images also show some other aspects of what these young men and boys ideated to in terms of their futures. So on the left, you can see a young man drawing himself as a successful professional. He's a doctor wearing a lab coat. And then you can see 2 years later, he imagines himself with a woman who he described as his wife and with a baby. And this was really common, that boys ideated towards having careers where they could provide, followed by marriage and children. And on the right, you can see another life history narrative in terms of their future ideation. This participant, you can see in the top right corner, he draws a big, sizable concrete home surrounded by green leafy trees. And he also says that he wants to have 3 children, a lovely family, and you can see an emoji showing a smiling family. And he writes that he wanted to be an accountant. And while the things shown in these images, such as being a professional, having a nice home, getting married, and having children, might not be unique to adolescent boys living with HIV, these things might be additionally important for this group because they're markers of masculinity. And given that living with HIV is still perceived as a barrier for men to have intimate relationships, children, and to breadwin, achieving these dreams represents survival and becoming successful men that their fathers didn't have the opportunity to be. And within this context, it's really important to mention that this was within a post-apartheid landscape, which saw systemic marginalization of Black and racialized folks and the intentional splitting of families through the migrant labor system. And a key takeaway from these findings is that adolescent boys living with HIV have full lives and big hopes for the future outside of their HIV positive status. And like Rose mentioned, interventions with adolescent boys might respond to these interests and be multifaceted and include hopes and dreams for the future rather than focusing solely on HIV and health. And the next findings that I'll share with you are from a recently published paper on the health beliefs and practices of adolescent boys and young men. And boys really describe conflicted relationships of taking ART while growing up because it interrupted their ability to feel, and this is their words and terminology, quote unquote, normal. And they related their HIV medicines taking to the challenges surrounding their HIV status, such as parental loss, illness, and the frustration and shame of living with a highly stigmatized chronic condition. And they described trying to distance themselves through their HIV status through stopping taking pills. And then once they started getting sick, starting to take them again. And the clinic files also corroborated with these accounts and showed gaps in clinic attendance and ART adherence. As participants became older, disengagement from care appeared to be more pronounced, and this was especially true when they stopped being accompanied to the clinic, which interestingly happens younger for boys than it does for girls. And what we believe was happening as they got older is that the pull of masculinity became stronger, and adolescent boys, as well as their health workers that they work with, described older boys as behaving in similar ways to adult men. For example, they spoke about refusing to acknowledge sickness or pain and only seeking care when health issues became so bad that they couldn't endure it anymore. And what seemed to be happening was that pill taking and clinic attendance became an avenue to demonstrate autonomy in adulthood and also to start to perform hegemonic masculine norms. We also included in this study some research with traditional health practitioners. And in Southern Africa, this is really important because many people access traditional health services. And the evidence on adult men suggests that men living with HIV might be more likely to engage with traditional care because of the privacy and the respect that they are afforded in these services. And there have been concerns and documented challenges with non-adherence to ART for men who are engaging with traditional care, as well as negative side effects from mixing antiretrovirals and traditional medicines. However, what we found in this study was that although most participants had gone to a traditional healer, there were very few accounts of ingesting traditional medicine. And participants described being aware of and avoiding potential interactions between antiretrovirals and traditional medicine. And again, we think this is probably due to broader knowledge as well as their specific experiences growing up embedded in the health system. Participants demonstrated really strong biomedical knowledge about HIV and treatment literacy, and they did not believe that healers, traditional healers, could treat or cure HIV. Despite this, many did have underlying beliefs about the causes of HIV, including relation to supernatural issues such as witchcraft, ancestral wishes, and divine will. And really the key takeaway here is that biomedical practices can occur alongside traditional cosmologies of health and illness. And in contrast to the literature, participants didn't at all use traditional services for HIV because they didn't believe they could work. And what we hypothesize is that growing up deeply embedded in the biomedical health system really shaped these participants' beliefs and practices. And this speaks to the importance of considering not only gender and culture, but also early experiences of childhood illness and research and intervention with adolescent boys and young men. Boys also told us about their experiences in health facilities, and unfortunately, findings point to really negative experiences of institutional discrimination, which served as strong deterrents to retention and care. So specifically, and Wole talked about this at the beginning, stigma was a really big barrier to accessing health services, and participants described being afraid of going to the clinic for fear that people would learn of their HIV status. And some health centers looked quite similar to the open source image seen here, where they had a separate waiting area or a separate bench that was specific for people with chronic medication. And other clinics had color-coded folders where they would color code the folders for people taking chronic medication. And what these practices did is they deterred participants from going to the clinic because they felt visibilized and stigmatized. And this was especially true when they stopped being accompanied by a caregiver to the clinic, which happens earlier for boys than girls. Girls and women might also not feel as visibilized at the clinic because it's more common for them to attend for reproductive health services. And the last really, really common deterrent described by boys in the study was mistreatment in the form of shouting. So some of the key takeaways here is that confidentiality really matters, and that extends to health facility layout as well as practices, even things that might seem very simple or benign, like color coding folders. Shouting health workers were also a very strong deterrent, and this corroborates very strongly with what is known about stigma, confidentiality, and adult men. Some potential supports that I think bear consideration are confidential spaces and practices. Another idea is to provide accompaniment to the clinic for boys later, potentially through buddy systems or community health workers, so that boys don't get stressed out and then leave the facility. And male providers' times and services also bear consideration. So another important takeaway from this study was that gendered contexts are really important, and there isn't a one-size-fits-all model to intervention. And I'm going to briefly share a context-specific example to illustrate this. So these are two other images of life history narrative interviews that we conducted with adolescent boys. And what was a very common theme that I did not expect in this research was that boys told us that traditional initiation and circumcision shaped their health practices. And within closest society, traditional initiation is considered to be a really powerful organizing factor in masculinity. And there's a strong distinction between boys who have not gone through this process and adult men who have. And during this period, there's an imperative to not take biomedicine for about a month when boys are at initiation and the 3 months when they return as men. And we heard a lot of this. So people saying if you're found taking medicine, you'll be called names and considered less than a man. And traditional initiation has a very strict code of conduct if you want to complete the process properly to become an adult man. And one of the things in this code of conduct was not being able to take pills. And you could imagine how stressful this could be for an adolescent boy on antiretroviral therapy who risks never becoming a man if he's found to be taking antiretrovirals. And for this reason, many boys stopped taking pills during initiation. And it wasn't just that month of initiation, but it was also the 3 months following where initiates were highly visible as new men. And during that time, new men, or amakwala, wear clothes such as those pictured here, including caps, trousers, and blazers. And what these clothes do is they show their status as new men to the community. And it's a time when they're highly surveyed and tested to see if they followed the rules of manhood properly. And these 3 months saw a lot of disengagement from care for adolescent boys living with HIV because they didn't want to go to the clinic and for people to think that they didn't complete initiation properly or that they'd had a botched circumcision. And after this, many didn't return to HIV care. Through collecting these stories of different boys' experiences, we also were able to determine factors that were supportive of boys continuing taking their medication. I won't go too much into this because I know this is very context specific, but the key takeaway here is that the importance of learning about already existing and contextually grounded solutions and interventions can support adolescent boys and young men living with HIV. Before closing today, I wanted to turn now to a few methodological lessons learned. And I'm going to start, just because we've been talking about traditional initiation, about how this is a really highly sensitive and secretive practice, and women and people from outside aren't supposed to know much about it. What I've shared today is within the realm of what is within acceptable public knowledge. But right at the beginning of my field work, there was a movie that was put out about that was set against the backdrop of traditional initiation, and it came out, and in the local theater, there was actually a fire set and protests over this film. So that's just to show how secret and sensitive this topic is. And this posed a big ethical dilemma for me as a woman and as an outsider. And on one hand, boys were speaking about this time that has really far-reaching health impacts. And on the other hand, I didn't want to engage closely with something that as an outsider, I wasn't supposed to know about and it wouldn't be acceptable to engage with. And what we ended up doing is following the lead of these two young men, Sinabongo Mbula and Pakamani Kom, and they're pictured here at their request. And they conducted interviews with boys, and then they did not actually transcribe or share any of the secret or sensitive issues that came up in those interviews as a way to respect cultural norms. And this experience really begs the question, who is best placed to work with adolescent boys and young men? And it really highlights the importance of positionality and intersubjectivity. And there is a common assumption that participants and adolescent boys and young men accessing services are generally more comfortable with someone of the same gender. And this was partially true for this research. And while it was really important for CLOSA men to conduct this research and to be ethical advisors, there were also a few areas where demographic difference was preferable. And I just wanted to share these because I think it's an important part of the conversation that often gets overlooked. So for example, we were strongly encouraged to recruit men who were older than participants, so they would be respected and taken seriously. At the same time, they shouldn't be too old because they might not, participants might not open up as honestly, especially about issues related to sexual health, because of strong age-based hierarchies where certain topics shouldn't be talked about with elders. Another example where an outsider or some demographic difference was preferable was that the researchers didn't want to interview participants from their own communities, and they suggested rather swapping. So for example, Sine would interview participants from Pakamani's community and vice versa. And the reason for this, they explained, was that close social proximity between participants and researchers meant that participants might not feel as safe or comfortable during the interview, and that living in the same community could also complicate personal and professional boundaries. And I think this is really important to think about when we think about different models of providing services for adolescent boys and young men. And it can be really applied to HIV services and programs as well, and thinking about how geographic and social proximity can really inform service delivery uptake. But to step back for a second and just say the key takeaway is that positionality and intersubjectivity are really important to consider in who is best placed to work with this group, and that demographic sameness and difference can have benefits and drawbacks that need to be closely considered. I just wanted to share two other very quick methodological learnings and findings. So another methodological lesson is that the way that boys perceive researchers or service providers likely will shape the ways that they seek help. So in this research, we received many requests for referrals to different types of support. And Pakamani, who you can see pictured on the left, got many requests from boys for support with substance abuse challenges. And our hypothesis was that participants felt comfortable sharing this type of challenge with him because he had a laid-back attitude and a relaxed style, and they rightly assumed that he was not judgmental. Sinabongo, who's pictured on the left, received very different requests for support. So boys frequently went to him for guidance on how to apply for social grants and for advice related to circumcision and becoming a man. And as someone who appeared to perform to close traditional norms of manhood, boys might have seen him as an authority on this topic. And what we learned from this, and the key takeaway, is that adolescent boys and young men's disclosures and help seeking is shaped by the expertise and personalities of the service providers and researchers. So just something to think about in terms of how service providers are perceived and how this might powerfully influence interactions, as well as the effectiveness of the rollout of services to adolescent boys and young men. Before closing, the last thing that I wanted to mention is the role of different approaches in working with adolescent boys and young men, including art-based methods in research and programming. In our research, as you saw earlier, we used emojis in life history narratives. And what we found these did is they facilitated conversations and elicited expression on issues that might otherwise be difficult to speak about, especially for a group that isn't often encouraged to open up and share about feelings. So emojis, as well as alternate methods such as songs, might make boys feel more comfortable and might be more familiar. And we actually ran out of all of the crying and angry emojis that we could find in the region. So there were a lot of experiences and expressions that boys chose to put forward through that form. And while that might seem small or even silly, we have a lot that we really need to learn from this group, and we need to hear their stories, and finding creative ways that meet adolescent boys and young men where they're at might go a long way. So I will leave it there, but I wanted to thank you very much for having me today, and also the incredible research participants, research team, co-authors, and funders that supported this work. And I welcome any questions that you have. Thank you.
Thank you so much, Leslie, for such a comprehensive presentation. Very insightful. We can see from the Q&A and also from the charts in the box there. So colleagues, we're going to be going into the Q&A section, and Sean Malone, co-chair of this main group as well, will be facilitating that. We have heard from Wale, who provided an overview summary of the framework, this resource that we think is very powerful and useful for those who have not been able to see it or to be part of the ICASA session. And also we've heard from Rose and now from Leslie around, or insights around reaching adolescent boys and young men, and some of the issues around health seeking for this population. So over to you, Sean, to facilitate the Q&A session. Yes.
Great. Lysias, can you hear me fine?
Yes, perfect. Yeah.
Okay, fantastic. There are a couple of questions in the Q&A that Wole has offered to respond to. One is this question around person-centered care and whether we complicate things or make things difficult by subdividing it across so many different target populations. Wole, do you just want to jump in with some thoughts on that?
Yes, absolutely. I think, yeah, that was, I saw that as a very fascinating question. But, my response really is to say that I agree, right? First of all, the framework, and I'm hoping you're going to get a chance to, peruse and have a look at it, follows exactly what you've mentioned. It's more about a people-centered approach rather than a vertical siloed approach just for men. I think one of the things that I'll also say is that resources, especially in low resource settings, we have to be able to, and again the framework emphasizes this, use existing resources, so existing services, existing health workers, existing structures to be able to deliver integrated services for men. So I am completely with you in that thinking that we do not need to be siloed and create very separate structures for men. However, we also have to look at the other side, which is the differentiated approach. We speak about differentiated service delivery. We have to be able to sort of combine those. So using existing structures to to provide differentiated male responsive services that can get us to where we need to be. Over to you, Sean.
Great, Wole, thanks for that. While I have you, let's just tackle that other question in the box around possible tension between treatment as prevention, U equals U, and other forms of primary prevention that we're perhaps more familiar with. Do you want to comment on that as well?
Yeah, absolutely. I think, and again, not to be misconstrued, especially that that paper from Mahmood et al., which showed that had we suppressed the virus, or had we had virus suppression in men, we would have halved the new infections in women. That, of course, speaks to treatment as prevention, and we saw from that cascade that men are really quite down when it comes to accessing ART and being retained in care. So without a question, we must, following the evidence, we have to make sure that we increase coverage of antiretrovirus for men, not just for themselves, but for women. But that's one side of it. Now, the other side of it, of course, is prevention. And there's been, especially in the last couple of years, a lot of chatter about, what is not just prevention, but precision prevention and cost-effective prevention. So in this slide, I'm going to, say that, certainly primary prevention is going to be moving forward a very key part of what we are working on. But in particular, we have Again, this was mentioned, in some of the presentations today. Voluntary medical male circumcision, which is, so key. We know how effective this is, and it's reached so many men as well. PrEP, of course, event-driven PrEP, but also, other forms of PrEP, pre-exposure prophylaxis. But then again, something I've seen in the chat box is, good old condoms, right? Condoms, we know it's cost effective. We know it's readily available. We know that it is, it also prevents not just, HIV, it's multiple use, it's STIs, it's pregnancies. What's on all, we have to see how, we can, make, condoms, bring it back, get it sexy and get men using condoms as well. So those are, really effective, cost-effective solutions as well when it comes to primary prevention, which we must not lose sight of as we ramp up ART coverage as well for men. Over to you, Sean.
Great, Wole, thanks for that. We've got a question for Rose. Rose, I know the time was tight and you had so much to present, but we did have one question around if you could say just a bit more on the profile of the adolescent boys and young men that was being studied in the review that you conducted. I imagine that might vary greatly, but is there anything you can say about the types of adolescent boys and young men that you were looking at?
And for those that included, that looked at the out-of-school population, majority of them were unemployed, and therefore interventions targeted to reduce their outdoor time and introduced interventions such as soccer games and social protection programs so that they spend more time in profitable things rather than just being idle. And for those that were targeted at in-school populations, those were the ones that had the educational curricula. I don't know if I answered correctly.
Great, Rose, thank you. Yeah, I think we can take follow-ups if anyone has any. The other question that came up in the Q&A box was how much did you come across the issue of mental health for adolescent boys and young men? And do you see a need? Do you see a response? What was your observation there?
We didn't look at mental health. We excluded it out of our intervention, so we didn't look at it. But rather, I've come across interventions that look at mental health per se. And for some, I've never read them in detail, but for those I've read, they are successful. And I think it's profitable, it's necessary for us to include mental health in all these interventions.
Great, thanks for that. Colleagues, we do have about 8 minutes left. If anyone would like to use the raise hand function, I believe we can take you off mute and let you ask questions directly to the speakers. While folks are gathering their thoughts, I thought I might just pose the question to Rose and to Leslie. Both of these presentations were so rich, and I know we'll circulate the presentations after so that folks can go back and remind themselves. But if you had to leave this group with just maybe 2 or 3 takeaways on how we can do better by adolescent boys and young men, what comes to mind for you? What do you want people to walk away with? Rose, maybe we'll start with you.
Okay, thank you. I'd like for us to also look at boys not as perpetrators, but also as victims. And we'd also like to give a voice to boys to determine what they really want and to give direction. I believe that if we do that, they will be responsible for their own change and will find positive feedback in response to the HIV/AIDS pandemic.
Yeah, I can just, I totally agree with Rose, and that's actually what I wanted to say as well, but because she said it better than I could, I think one additional thought is that adolescent boys and young men have very complex, multifaceted lives, hopes and dreams for the future. And I think seeing them in that way and focusing interventions in ways that can meet multiple of their needs is really important. And I think this is also important because boys occupy what has been referred to as a space of marginality within hegemony. And what that means is there are multiple forms of marginalization, especially for a lot of adolescent boys and young men living with HIV, that if addressing those, if providing meaningful opportunities, meaningful work, and things that validate other aspects of their lives and identities, I think can go a long way in supporting their health.
Great. Thanks both for those summary thoughts. I'm not seeing any raised hands. Let me just check the Q&A box one more time. Okay, we do have a question from Ephraim in, I believe in Namibia, asking about strategies that we could take into the educational system. Either of you have any thoughts on how we might integrate better with health and education?
I agree. And I think that's one of the areas where there is some evidence of effect is within education. I think that works very well, especially for prevention. I do think we also need to be thinking about targeted treatment interventions for adolescent boys and young men who are already living with HIV as well. And those could happen within the education system, but I think also additional social supports outside of it would be needed too.
Great, thanks, Leslie. Rose, any thoughts on that from your side? Interventions within the educational system?
Yes, I agree. Interventions within the educational system are effective, but we also need to include out-of-school population because especially in Africa, not everyone is in school. So we need to include everyone and not leave anyone behind in the AIDS response.
Great, thanks both. I'm still not seeing any hands or any new questions. So Wole, I think I'll just hand back to you for closing thoughts.
Yes, thank you so much, Sean. I think it's been it's been quite compelling, I have to say. You know, listening to Rosalind and Leslie, I think there's a lot of insightful work that is being done, and you know what it just makes me excited. I have to say, I'm feeling, you know, having listened to both speakers, I'm feeling excited. I'm feeling you know very hopeful as well in terms of what is to come and what is possible. You know, there are just so many opportunities from research, you know, to service delivery, and you know, sort of collaborating as well. You know, bringing together all of the parts to move this this work forward. I thought there were some really you know, really great questions as well. You know, always I hope that we drive more participation for these webinars. I'm not sure we're doing you know, a good job of disseminating the links and, you know, trying to get people you know, into this space for discussion. But you know, all in all, I thought this has been a really great webinar. So let me thank, of course, the presenters, Rosalind and Leslie, for taking the time. But also to say that I hope that this is not, and we're going to have, you know, some more continuous touch points, you know, with you. I think we need you to help us with thinking through a lot of the elements that you've mentioned here. I was quite struck as well, you know, with you know, from the presentation, some of the dynamics between either mixed gender interventions vis-a-vis sex pre-segregated interventions. So my call to you, Rosalind and Leslie, is to see how we can take this forward, particularly with the smaller men and HIV technical working group, and to see how your work can inform the discussions that that happen on this platform. So thank you so much for your work. Of course, Lysias always doing great to bring us all together and coordinate. And Sean, of course, who are really the brains behind the webinars. Let me send a shout out as well to the Men and HIV Steering Group. They are the ones who on this platform we sort of bring these webinars together. We're going to be having our first quarterly meeting in March. So hopefully we're going to be able to, with Lysias and Sean, report back on especially the work that Leslie and Rosalind have presented. Link that, see how we can link that again, to the framework, the new framework that we have, and sort of see our next steps on that. Let me thank, of course, all of the attendees. You've been amazing. The chat box has been a beehive of questions and so on. So thank you so much for that. And then finally, of course, the translators and the interpreters and the IT, from UNAIDS, they have done really well to to keep us in check and to also help to resolve any tech issues. So this is just the beginning. So we've laid an early marker. So this is January. We started our webinar series so early in the year, which is intentional. We wanted to start really strong so that the rest of the year can be can be quite solid for men and boys. So I'm going to ask you to stay tuned, stay with us, and let us continue to move in this light to support men and boys, not just for them, but like I said, and like all the presenters said, for the general response as well. It is so critical. So thank you so much, everyone, and we're going to see you again soon. Bye.